Good morning. So we're going to talk about a case that might help you take care of a patient with a polyp, and I would like to thank Selvi, Roy, Sylvia, and Sriram for helping us discuss this case. And we also have a poll as we go along. And I would like to thank Dr. Stroline, my mentor, Mr. Charles Butt, for their support. Angela Deal, who helps me with the medical illustrations, and my institution for allowing me to do these Zoom classes. So we talked about in the past, what all steps that we will normally go through when you see a polyp and before you resect. And we will spend a lot more time on the evaluation part of the polyp in this session. And the goal of this talk is to go through how to manage bleeding that happens during a polyp resection. And as we know, there are several different options that you're aware of. You could use cautery, either with a snare using a soft coagulation, effect 80 watts, or if that bleeding cannot be controlled, you could use a hemostatic forceps, again, soft coagulation between 50 to 80 watts. And sometimes you could use APC as well. And when it comes to mechanical hemostasis, I think clips have certainly revolutionized endoscopic surgery. Loops are useful, but they're predominantly for management of patients with pedunculated polyps. So we're going to talk about this case. So this is a case that I've actually seen a few years ago. This is a middle-aged man who came for colon cancer screening. And this is what you see. So you can see the lesion there. And so I'll request Selvi to run the poll. And let me run this video one more time. And how do you describe this lesion? Is it a pedunculated polyp? Is it a sessile polyp? Is it a laterally spreading granular tumor? Is it a laterally spreading tumor of the non-granular type? So let me run this video so much. I thought I'd replay the videos again so that you have another opportunity to look at it. All right. Selvi, you may want to end the poll. Okay. So Sylvia, what do you think? Roy?
It's hard to be sure without moving it around. In one view, it looks like it's pedunculated, but I don't know if it's continuous towards the appendix or not. So I would try to move it around using a tip of a snare, or another way is that I would put some water there and see if it floats.
Okay. So we moved it with the tip of the snare. It did not move. And we tried to go underneath the lesion, and it is still there.
So then this would be classified as sessile polyp.
Why not? A lot of people picked up a laterally spreading tumor granular type. Why is it not a laterally spreading tumor granular type?
Well, number one is that the this concept of laterally spreading tumor was first, I think, described by Dr. Kudo. And the way the thinking was is that when you look at the lateral spreading tumor, you think, why would a polyp be growing to the side rather than growing upward? And and if you try to apply that in this situation, you would say, well, this polyp is actually just growing upward more than growing to the side. So then by definition, then it is not a laterally spreading tumor. There was an old definition whereby a flat lesion is when the height is less than a half of the width. So this is, you know, clearly the height is so much more than the width. There is no way that this could be part of a flat lesion. Laterally spreading tumor is defined as a flat lesion larger than 1 centimeter in width.
Okay, all right.
So Raju, may I have a comment?
Yeah, please.
I think that's a very good example. It is sometimes difficult to differentiate a laterally spreading tumor from a sessile polyp. What we could do in this case, we could insufflate air and desufflate to make a better judgment of the height of the lesion versus width, as Professor Sutikno explained. So this would help some maneuvers to better differentiate between a sessile and laterally spreading tumor.
Okay, that's good. So it looks like it's good idea to say it is a sessile polyp. You guys agree with that? Is that your thought process?
Yes.
Yes.
Okay, that's good. Okay, that's good to know. I think it's a. So the next question is, before you resect, you would want to say what type of Paris classification and what is the likely pathological diagnosis, and what's your optical diagnosis? Is it a hyperplastic polyp? Is it an adenoma? It could be tubular villus or villus. Or is it a serrated adenoma? Or is it a cancer? All right. Sriram. What do you think, Sriram?
Sriram is saying he doesn't have a mic.
He doesn't have a mic, okay. Let's see. Sorry about that. Sylvia, you may want to comment on that while I'm trying to get.
Yes, I would go for an adenoma. I don't see the color of the lesion very clearly, but in my opinion, it is somewhat darker than the surrounding mucosa. So that is why I would not choose for hyperplastic polyp. And I don't see macroscopic signs of submucosal invasion. So I don't think it's an adenocarcinoma, but of course, a large sessile polyp of this size should be maybe about 2.5 centimeter, in my opinion, has a risk of containing adenocarcinoma. So to answer the question, I think it's an adenoma.
Okay. Sriram, what are your thoughts? I think I made Sriram.
So Raj, yeah, I don't know that he has a mic yet, Raju.
I made him as a co-host. I think I made him as a co-host.
Raju, in the meantime,
Okay.
there was a question in the chat. We had that excellent session with Roy and Sylvia and Tanya earlier a few weeks ago about the NICE classification. So there was a question in the chat about if you have a picture of this with NBI, that would help us kind of make that distinction a little bit better.
Right.
Do you have a picture with
So-
NBI?
Yeah. So the problem is, unfortunately, I did not do an NBI. You know, I wish I did that. I wish I could have shown this. But when I looked at it, it had the features of an adenoma, and I felt, you know, that's good enough. I wish I did the NBI to show you that. Right. Sriram, are you open now? I think Sriram is a co-host actually, but I don't know. Okay. Right. So let's go to the next one. Where is the lesion? Is it in the cecum in a non-dependent position? Is it in the cecum in a dependent position? And is it in the ascending colon, non-dependent position? Or ascending colon, dependent position?
Hello?
Yeah.
Yes.
All right. Roy, why is it important to ask this question?
I think you know, it is more important if it's was something that you want to loop. I don't quite understand why you're asking that when it's sessile. I think the position right now is ideal for injection and then resection. Unless you are thinking to do it underwater or something like that.
Okay. I will explain a little bit later. I don't want to give up
Okay.
right now. Okay. How are you going to resect this lesion?
Very well.
Hot snare, cold snare, EMR, or ESD?
Oh, don't you start with a cold snare in the morning like this.
You know, it's important to give all the options, right? You want to make sure that you are on both sides of the aisle.
Mm.
All right.
Oh, that's
Sri-
good.
Right. Is Sriram's mic is open or not?
Yes, sir. I apologize for the
Sorry
delay.
about that. Sorry about that. Yeah. So what will you do,
Yeah,
Sriram?
well, I would try to do EMR if at all possible, and once I inject, I would know better.
Okay. All right. So the other question that I want to ask the panel is, you know, if you go back to the history, this is a 55-year-old man who came for screening colonoscopy, and you found this lesion. First case of your day, and you have a full day of cases. What will you do? You will go ahead and do the EMR because you didn't talk to the patient about resection and the issues. I want to hear from Selvi, then Roy, then Sylvia, and Sriram. So would you do the procedure, resect now? Or do you say that, okay, I didn't talk to the guy about EMR and all the issues, I'll bring the patient back? And you have a big list of cases.
Well, that's always the case, Raju. But I think we need to do the best that we can for the patient. And the patient has gone through the prep. It looks like a very good prep. And they've taken the time off and they have the ride. And in our institution, they got their pre-procedure COVID test done. So I would resect. And the other caveat to that would be for all of the screening colonoscopy patients to advise them that there is, you know, probably around a 5% chance of finding or less than 5% chance of finding a larger lesion that would need to be resected. And then the risks of the procedure could increase in that setting, but that I would do the best that I can for the patient. That's what I tell every patient, is that I'm going to do the best that I can for you. No procedure is perfect, but I will do my best. So I think for the patient, I would resect.
Okay.
The other thing that I know that you like to do is, and again, this is pre-COVID, is to go out and talk to the family member and tell them that, we're doing this. It's going to take a little bit longer, but we want to do a complete job for the patient. But that's no longer possible at this point.
Okay. Sylvia, what would you do?
I think I would like to echo Salve's opinion and to add that even in the pre-COVID times, in the screening setting, we informed the patient prior to endoscopy that we can find large lesions and that we will try to remove them all in the same session to avoid additional burden for the patient and also for the screening program. So they are already informed about the risk of complications in a pre-screening session. And of course, I think that a lesion of 2.5 centimeters can be removed in the same session if he does not have many more additional lesions. So that's my opinion. Same session, if possible.
Okay. Sriram.
Yeah, I go with an open mind, and I echo Sylvia's comments about additional polyps. Personally speaking, anybody who would think that they would remove these polyps, their place and center and the team is pre-equipped to deal with these things even in their busy setting. So I do not see that itself as a limiting factor, but I would think that if suppose I personally have a habit of partly examining the colon while going in as well, and if I see any polyps which are sub-centimeter, I keep removing them as I go in. So if I have removed a lot of polyps, and this next to an appendix in the cecum with a larger polyp, higher risks of polypectomy. If I don't feel comfortable, then I come back. But if this is the only polyp I'm dealing with, I would just go ahead and resect and explain, because I also presume, not just for me, for anybody who is attempting to do this, we would have had these conversations before ahead at the time of consent about why we are doing and what we are likely to find occasionally. So I would go ahead and resect.
Roy, what do you do?
I have an easier job here. Everybody have said what they wanted to do, and I just have to put it together. So it depends on like the patient. It depends on the staff. It depends on your location. So if the patient has a lot of comorbidities, for example, and you may need to prepare for this resection better. If the patient has medications that may need to be adjusted for these, those things are quite important. And if the patient also come from far away, and you may want to say, well, after this resection, you would need to stay longer. These things have to be really thought about before you embark on cutting something like this. The staff, I mean, you may have the staff for this appropriate setting if you're in the hospital's setting, but you may be in an ambulatory setting, and principle to just cut cannot be applied. So there are some mitigation issues that you really have to do your checklist before you say, okay, I'm going to cut it. As Sriram says, if you have like the entire team to cut this, something like this could be done in maybe 20 minutes. And you could just go ahead. But as far as the consent, usually we consent for the entire procedure, including cutting this. The part that may change these days is that endoscopy has become so expensive now. And it may not be fair to double charge the patient. I don't know. At MD Anderson, I would think that colonoscopy would be charged about $5,000 to plus dollars. And if the patient have a lot of copays, you may also have to put that into the equation and say, hey, I may just have to go ahead.
Mhm. So, first of all, I want to bring this to discussion because this is an important point for the sake of trainees. And I'm glad that we talked about different issues. One of the things that I used to do and still do is that I ask the patient if they have any travel commitments. When you are practicing in a big city with a big major airport and a seaport, you would be surprised that how often people will tell you that they are flying to some other place. And this is a polyp that I would not cut if somebody says that I'm flying to Europe next week, because on a flight, if they have a bleed, it's going to be a big issue for them. And I also ask them whether they're going on a cruise. Because in the last few years, making it a routine to ask these questions, I found at least 3 or 4 patients who said they had major holiday plans with international travel. And one patient said, okay, if I find polyps, I'm going to cut or whatever, what do you want me to do? She said, no, I don't want to go on my travel. I'm going to come back for the procedure next time, even though I have done the prep. Something to keep in mind. And when I shared this message at one of the ACG annual courses, one gastroenterologist came to me and told me that I'm glad that you shared. And he shared that he had 2 patients that required transfusions in the airport. Those patients bled after polypectomy, and they required transfusions. So it's something to keep in mind. All right.
Funny you mentioned that. I just had a patient last month who had he had polyps that I removed, and later on when I was trying to educate him about follow-up and need for watching for any rectal bleeding, etc., then he told me that in 1 week he was going for a hunting trip, and by no means he's going to come what may, he's not going to postpone that. And then I had to physically look at the options for him to where to go nearby to seek help in case he ends up with a problem. So I really appreciate you talking about this.
Right.
Mhm. Mhm.
All right. So we injected quite a bit of fluid, and we took a large snare and to cut the polyp. And as you can see, it's almost 40 ml of fluid that was injected, and we decided to cut. And we thought that we should be able to cut en bloc, but we cut a large piece. It looked good, but you started noticing bleeding at the base. So you have this problem of bleeding from the base, and the polyp was cut 80–90%, but you still have something. And what will you do? Are you going to take epinephrine? Although we injected epinephrine into the solution, used epinephrine in the solution initially, or apply a clip, or use a coagulation grasping forceps, or a loop. So while the poll is going, okay. Roy, what would you do?
I think the bleeding in the short movie that we had didn't show like it was like massive. It's probably arterial. So it would be easy to just use grasping forceps to take care of it.
Okay.
That way, then you don't have this limitation of having a clip sitting in the middle of the resection plane while you're like trying to make sure that everything looks good at the end.
Okay.
Loop application is perhaps not ideal here because after you have cut, there's really nothing to loop. There was nothing to loop to begin with. So that's not as ideal.
So this is what's happened, there was a lot of bleeding. The resected polyp was in the base, and we couldn't see the exact site. We thought it maybe it's at the top edge. And we tried to grasp that a little bit blind. The guy was respirations kept the area moving, and despite that clip application, there was continued bleeding. So the bleeding continues despite the clip closure. What would you do next? Are you going to deploy the clip, come out, or do epinephrine injection, or use a coagulation grasping forceps? The reason we didn't go for coagulation grasping forceps here is at that time we didn't have that in our lab. This was a video that was done about maybe 8 years back. Or because you find the bleeding, you rotate the patient to define the source of the bleeding. All right. Sriram, what will you do?
I agree with rotating the patient, but more importantly, if the anesthetist permits, if his vital signs allow, I would first, before I rotate the patient, I would try either tilting the head end of the bed up or the bottom end up to see what if it would shift the blood away to allow a little better visualization. If not, then I rotate the patient.
Okay. Why?
I think it's also important in this setting, looking at your movie, that here is like one of the bigger issue that we now often face because we are so dependent on having the anesthesiologist giving sedation. And a lot of the time they actually think that you're about to do a colon transplant, and they sedate the patient like there is no tomorrow. And it's so hard to do this kind of procedure, of resection or clipping when the diaphragm moves so much and the colon also moves. So I usually negotiate with my anesthesiologist before I start. In fact, last Friday I had to negotiate with the replacing anesthesiologist because he thought I was about to do a cecal transplant. And the sedation was so much that the patient was snoring, and it would be impossible to do something like this. In the old days, when we do a lot more moderate sedation, problem like that doesn't seem to happen as much. So you need to say, please don't sedate so much. Just sedate it more lightly. Then you can do this type of procedure much more precisely.
This is so important, what Roy said, with more and more anesthesia personnel being involved, having a dedicated anesthesia team or routinely the same people doing anesthesia for our cases makes it much more easier for such communication. And sometimes somebody is on vacation and someone else replaces who works generally in the OR and now comes to endoscopy suite. They consider all these cases require sedation like an open surgery, which is not the case, and then we end up with problems. So it is so important what Roy said in terms of having communication with the anesthetist and sort of negotiate.
Yeah. So I want to share a couple of thoughts. One is when I first joined MD Anderson, we did not have that much of anesthesia support. We had it only for 2 rooms for ERCP in the US. And all the colon polyp EMRs were done under conscious sedation. As part of my visit with the patient in the clinic, I shared with the patient that I will sedate them lightly and explain to them that I would need you to hold your breath at different points in the procedure to allow me to do a better injection, or if there were to be bleeding, if you hold your breath, the abdomen will be still and the colon will not be moving, and it would allow me to find the bleeding source and treat it easily. And then when we started having TIVA, or the monitored anesthesia with propofol, I ended up having a lot of problems with the deep respirations from the patient with a lot of movement of the colon, like you saw here. And then I made it a point that all my EMRs will be done under general anesthesia, and with even to the point of paralyzing the patient, especially if I have a lesion in the transverse colon or in the hepatic flexures, because that area could move quite a bit with the respiratory movements. So that has certainly helped. So figuring out how to keep the colon still is very important. I'm glad that we talked about it. It's a very important point for the sake of trainees. All right. So we rotated the patient, and as you could see here, you could see the bleeding coming from the top end. And we thought that, okay, although we couldn't see the vessel, that we thought that, okay, that's the bleeding part. And we applied the clip or closed the clip. And as you notice, the bleeding stopped immediately. And that was probably one of the most important things I've done to take care of this patient, that is rotate the patient. So what will you do next? So you still have a polyp to be cut, and will you deploy the clip immediately or do not deploy the clip? So when you applying clips, you tell the assistant, open the clip, close the clip, and deploy the clip. And he has to follow your request and not jump and close the clip and deploy, because you want to make sure that you educate your assistant that he has to follow. Open the clip, then he opens, close the clip, he closes. And then when you say deploy the clip, you should deploy. So half of the people said to deploy the clip, and about half, 40% said do not deploy the clip. And this is something important. So what we did here was, because there was still a lot of polyp to be cut, and we felt that, okay, we apply the clip, use the tamponade for 4 to 5 minutes. By the time there will be a thrombus that will form, and bleeding will stop forever, and then reopen the clip, and then do whatever needs to be done. So once the bleeding stopped, we kept the clip on there for at least 4 to 5 minutes. And then, as you can see, the bleeding continued to stop. We injected a little more, lifted the lesion, and completed the cut so as to complete the job in the same setting. If you applied the clip and you entrapped a little bit of a polyp in the clip deep into the submucosa, that polyp would come back and make it very hard for you to ensure a complete eradication of the polyp. Like every other case, we apply APC at the edge to prevent a delayed recurrence. And then we close the defect with the clips.
Nice.
And we know that large defects, complete closure has been shown to be beneficial in preventing delayed bleeding. So let me conclude by saying that, when you have a large polyp in the cecum, first thing is you want to make sure that there's no cancer by looking at the surface features. And when you want to resect, consider submucosal injection with or without epi. Like we talked about here, we use epi. And when you have immediate bleeding with a little bit of residual polyp, nowadays you have several options. If it is a small bleed, you can do a snare tip soft coagulation. If it is a bigger bleed, you could use a coagulation grasping forceps. And if you don't have a coagulation grasping forceps, which is about a few $100s in cost, and you have a clip, you could use the clip application for mechanical hemostasis. Sit there for 3 to 5 minutes, reopen the clip, and then apply, remove the residual polyp, and then close the defect. The other thing is when you have a polyp that is dependent, like here, if the cut goes and there's no bleeding, there's no problem. But if the cut goes and gets complicated with bleeding, like we saw, a big vessel bleed, then you will struggle to find that bleeding source. So if that happens, rotate the patient or do something to push the blood away, and then treat the lesion. So these are the concepts that I wanted to share by presenting this case. I would like to take a couple of minutes. We talked about, in terms of the bleeding, you need to think about the patient factors, the polyp factors, your team factors, and also the other issues, whether somebody is traveling or not. And as part of the talk, I thought that I want to share the blood supply of the colon, which is very important to keep in mind. You have basically three, this is the arterial supply to the colon as it penetrates through the longitudinal layer. There's one plexus that stays here in between the circular and the longitudinal layer. And there's a larger plexus in the submucosa. And then there is a smaller plexus in the mucosa that actually helps you to define the type of the polyp. The brown areas that you see when you do NBI are the capillaries as part of the mucosa plexus. And why is this important to know? Because if you think about pedunculated polyps, as the stalk increases in size, they tend to have multiple feeding vessels. It's not one feeding vessel. So when you're trying to cut a pedunculated polyp, you have to cut it in such a way that you are achieving hemostasis of all the vessels before you cut. And if you cut too fast, you'll have bleeding. When it comes to sessile polyps, again, as the size increases, you have multiple feeding vessels, and that is something to keep in mind when you're cutting. So it is possible that when you take a large snare and try to cut a large section like we did here, and some other vessels escape the coagulation effect and they bleed. So as a fellow, if you want to cut a large polyp and you want to play safe in the initial part of your practice when you go out, probably not a bad idea to take a smaller snare. Start with a 10 millimeter snare. You may end up cutting a little more number of polyp, segments of polyp, but you will come out safely. So something to keep in mind. And we also talked about the depth of injury. As you know, that cold snare, most of the depth of injury is either to the muscularis mucosa or just below. And as you increase the current with cut and coagulation, the depth of injury increases and the risk of bleeding increases. One other thing that is important that we don't necessarily talk about is colon wall is about 3 to 5 millimeters in thickness. Cecum is probably the thinnest. And this is coming from the radiology literature. If you distend the colon, the wall is going to become much thinner. And as the wall becomes much thinner, your vessels are much more superficial and are more likely to get injured when you cut. On the other hand, if you decompress the colon before you cut and make the colon wall a little bit thicker, then you may not get into trouble. So what I typically do is before I cut, before COVID, I used to open the biopsy port out, the cap on the biopsy port to vent out all the gas so that the colon gets decompressed, and then put the cap back and get my snare in. With COVID, you never know, you don't want to have any spills. I stopped doing it. I just use a suction to decompress. That is not as effective as taking the biopsy port out, but I want to make sure that I'm cutting in a decompressed colon. And that is also helpful to avoid tension pneumoperitoneum if in case a perforation were to happen with a low colon loaded with a lot of air or gas. So we have a few more minutes. I wanted to apply these principles that we've learned. The principle is, finding out the polyp. Is it dependent or not? If it is dependent and you cut, if you have bleed, you will struggle to find the bleeding source. So learning from this case, I had a similar case, exactly similar case. Again, another lesion in the cecum, left lateral position, patient. Polyp is in the dependent position, as you can see. And then I rotated the patient from left lateral to supine position. And the polyp became non-dependent, as you can see here. It is not submerged. I did an EMR, and then there was bleeding. So you could see the bleeding spot nice and easy because it is not in a dependent position. And I used the cap to apply a little bit of tamponade effect there while I was getting my hemostatic forceps. So here is the hemostatic forceps that I'm using. We used a soft coagulation. Basically, you could see the bleeding spot nice and easy. Close. Make sure that the bleed stopped before you apply current. So we applied soft coagulation at 60 watts. You can go from 60 to 80 to 100 watts. And we tapped on the blue pedal, but we did not achieve hemostasis. So go back, increase the wattage to 80 watts, and apply some more current. And one thing is I want to make it a point here is when you're using a thermal modality device and you want to control bleeding, once you control bleeding, you pull back a little bit and watch. And if it is continued to bleed more, you just push it back and apply the current. Don't pull your instrument back into the channel and waste your time trying to go back and try to find a vessel. You can see that, we pulled back a little bit and then went back and applied the current. And before I pulled out, I opened and watched. And then once I was comfortable that we achieved hemostasis, then I pulled the instrument back. So here is a vessel that's been sealed with soft coagulation. And after that, you complete the remaining resection and close the defect. So I brought this case to show you two examples. One is the one where I struggled because of not realizing the importance of a polyp in a dependent position, and another one where we applied the principle. So why don't I stop here and we can have some questions and let the panel bring out some questions so that we can discuss this further.
Raju, I think we need to talk a couple of issues or comments. I think the mental representation of the picture of like where your injury is when you do cold snare and hot snare. I think what the audience may benefit is that what you would see if you had done a submucosal injection. So when you have done the submucosal injection, you would have expanded the submucosa greatly. And if you had done the snaring properly, meaning that you snare, and then initially when you snare, of course, you need to like snare with the snare pushed down to grab as much of a normal surrounding. But after you have like closed that, you would like actually tend up slightly and then release it so that you don't have a possibility of capturing the muscular spropia. But the one part that we actually don't discuss often is that when you do an EMR, by doing that, you actually will not cut too far down. And the vessels that you had drawn, the submucosal vessels, they tend to be traversing on top of the muscular spropia. That means that they are at the deeper part of the submucosa. So when you tend up, release, you actually would make the plane of resection not too close to the muscular spropia. Thereby, you will not injure, or you really should not be injuring the deeper vessels of the submucosa. So that's one comment that so maybe our next session we can show this diagram to show like what happens if you do the submucosal injection, and what happens when you close it initially, and then when you release it, you actually go far away from those vessels. So that's one comment I like to share with everyone. And the second one is that in a movie like this, without slowing it down, sometimes we don't see entirely, especially with the zoom, because the zoom also optimize the frame rate, so you may not see every single detail of it. But when Raju was doing the coagulation of the bleeding vessel on the second case, he actually had tented the close forceps slightly. And it is very important, especially for the beginning fellow, to understand that here is among the most important application of current density. So current density is the current divided by the area. And of course, when you have the smallest area, you have the largest, the highest current density. At the point where the current density is the highest, you will have the burn. So if you use the coag forceps and you do not tent it, the area with the smallest area may not be immediately at the tip of the coagulation forceps, but is actually deeper. And you could have a through and through burn, and potentially could cause a perforation at that spot. But when you tent it up, then you will create a neck at that submucosa, and that's the smallest area, and the vessel is right there, and then your burn will be localized superficially, and therefore you will not have a likelihood of perforation. In the old days, many of the current fellows do not know, we used to practice hot forceps biopsies. And there's a lot of complications of hot forceps biopsy. And the reason of that is that a lot of the time people actually do not tent it up. So then the burn is deep. I think this will also require like clarification with images so that people say, oh, okay, now I understand the concept of current density.
Well, thank you. Thank you, Roy.
So there's some questions from the chat. Dr. Espino asked if there was any opinion on the panel about the use of bipolar catheter in post-EMR bleeding versus coag grasper, so a hemostasis device type question.
You mean to use a gold probe?
Yeah.
Mm-hmm.
Yeah.
Versus coag grasper. What are the benefits? What do people use?
I think from the principal point of view, you could use bipolar catheter or coag grasper for hemostasis, but most of the literature, there's not much literature now on bipolar catheter for post-polypectomy bleed control, because if you look at it, bipolar probe typically was developed for treating peptic ulcer bleeding, and the peptic ulcers do have a lot of scar tissue in the base. When you apply, you may not risk a perforation, and the fear with post-polypectomy bleed in the cecum, applying tamponade similar to what we use for peptic ulcer bleeding, and then followed by bipolar current, you do worry about whether there's a risk of perforation with that. At least in the US, the options for post-polypectomy bleeding control are either a clip, first an epi injection if you need to slow down, or a clip. I've had actually tried to use a coagulation grasper in a delayed bleeding where I was not able to control because of a lot of granulation tissue and not able to find that vessel, even though I could see the bleeding spot. And then in a mushy area, it's going to be a little bit tough. Coag grasper works very well in an acute setting, that is bleeding that happens in front of your eyes immediately after your cut. When you can see a vessel, you can apply the coag grasper, secure the bleeding point, and then seal it with the current. So let me ask Alberto, do you use bipolar catheter?
Yes, good morning, everyone. Yes, I'm using bipolar with good results.
Mm-hmm.
Obviously, very gentle on the base of the submucosal. Sometimes because we don't have a coag grasper, so. Right. But I'm trying to use bipolar or the tip of the snare. Okay. But bipolar, I think so is safe, right? Because it's bipolar. I mean, it's no monopolar, and but I would like to know your opinion if you have any experience with that.
I don't have experience with bipolar, to be honest with you. If I say, for example, if I didn't have any other device, and a coag grasper in my unit, I would just go with a clip, and I would pick a clip with the broadest blades so that I could achieve mechanical hemostasis. And once you apply a clip and sit there for 3 to 4 minutes, you can secure the bleeding, and in that time, usually a clot will form, and then you can reopen and finish your job, and then close the defect. Sylvia?
Thank you.
Well, I don't have any additional comments, just a very instructive case. Thank you so much.
Raju, you had said for EMRs, EndoCut Q313. There's a question in the chat about if you would change those settings if you have a polyp or a lesion like this in the cecum. Would you make any changes to the setting on the ERBI machine?
So I basically use EndoCut 313 for all, for the last 10 years, I've been just using the same setting. The only time that I increase the cut interval is when I feel that there is a lot of meat to the polyp. A lot of meat to the polyp indirectly indicates a lot more feeding vessels, and I want to secure that bleeding, then I may increase it to 4 or 5. But it's also important to keep in mind, it's not just the settings of the ERBI, but how fast do you close or how slow do you close will impact your outcome. And that is one thing that we should, as endoscopists, take control and do it rather than relying on an endoscopy assistant, unless that assistant has been with you for a long time and you developed some comfort with that assistant. And if the assistant is changing every single day and you have not worked with them for a long period of time, it is better for you to do the snare closure so that you can maintain that consistency of snare closure. That is basically indirectly relates to the duration of current application. So the bottom line is I don't change the effect from 3 to 2 or 1. I just use 313. That's what I've been using for all my cases. In the cecum, that's what I do. So Asmin asked a comment about role of endoloop for hemostasis in a pedunculated polyp and issues to keep in mind with the endoloop. So let me ask Roy to answer this question, and maybe Sriram could answer. Roy has done a lot of work. Actually, he produced the first beautiful DVD for ASGE on endoloop application, almost maybe 15 years, 20 years back.
The use of endoloop is perhaps just strictly for pedunculated polyp. And even for pedunculated polyp, when you have the short, very short peduncle, is very, very hard to use. So we really don't use the endoloop for anything like a short peduncle or sessile. The use of endoloop is also limited by the current inability of many staff members to deploy it properly. And we have probably should have a session on how to properly use the endoloop. Because if you just use the endoloop by closing it directly, the loop will tend up, it will curl up, and then you will lose your target. So you will need to figure it out that you close it first using the outer sheath and make sure that it is in place. Then you slowly bring back the outer sheath and close the loop. It's hard to show this by words. We need to show it in diagram or movies. Other than that, is the endoloop has not taken into widespread use because of this issue.
Yeah. So there is a question from Hassan. So patient with rapid abdominal movements and snoring, any role for nasal trumpet to reduce abdominal movements? I think Selvi responded to that. Selvi, you want to talk about that so that everybody understands?
Sure, Raju. So from an anesthesia standpoint, it's usually an upper airway obstruction that causes snoring, and that goes along with a deeper level of sedation. as you mentioned earlier in the presentation. So mechanically kind of relieving some of that soft tissue obstruction that's causing the snoring could potentially help mitigate the snoring and then also the abdominal movements. So that can be achieved either with a soft rubber nasal trumpet that the CRNA or anesthesiologist can insert into the patient, or an oral airway can help also. That just basically pulls the tongue and the root of the tongue forward and prevents it from flopping back and obstructing the upper airway. Another thing that I do is to ask, I usually keep an eye on the propofol pump that the CRNA is using to look at the rate at which the patient is getting propofol. And I can generally tell them, listen, or another problem is not just abdominal movement, but the patient starts passing gas kind of continuously from their bottom. Then I can ask the CRNA to just reduce the rate of the propofol, and that way the patient isn't in as deep a level of sedation as they were. Those are things that can potentially help.
So one of the things that Hassan, I want you to keep in mind, and the rest of the group to keep in mind, is this. Colon polyp resection is like surgery. You want to have a stable operating field, to operate well. And you should not shy away from asking your colleague, if you have anesthesia support, to intubate the patient, especially somebody obese and somebody has sleep apnea and a short, thick neck, so that you can actually complete the procedure very fast with very little issues. On the other hand, say for example, you cut a polyp and it bleeds, and the patient is having rapid or deep movements of his abdominal wall, and the colon is moving up and down, like a boat, on lots of waves. It's very difficult to find that bleeding spot. Imagine finding that bleeding spot when the colon is moving all over. And then one would get frustrated and we will make mistakes. So it's very important to plan ahead and then try to do that. On the other hand, if the anesthesia support is not there, I will talk to the patient, and I've talked to the patients for almost 5 years in the initial part of my career here at MD Anderson Cancer Center, and told them that you will be awake for the procedure, and I want you to help me with the procedure by holding your breath when I ask you to do that. And that actually helped me take care of patients without major issues. And once anesthesia came on board, we started having issues because every anesthetist is different, how they take your patient into deep sedation. And some anesthetists are not comfortable putting those nasal trumpets. Others are very comfortable. And that actually determines whether you'll have a very smooth operation or not. So these are all things that, when people talk about polypectomy, they don't discuss, but I think if you get all those ducks in a row, you'll have a better experience and then enjoy.
Raju.
Yeah.
So you're saying that we should just put this nasal trumpet in a patient who seem to be having really deep breath, or is it for sure that it will resolve it or not?
If they have an obstructive pattern, it does help. But to me right now, I avoid dealing with that issue by having all my patients intubated under general anesthesia for large EMRs. So I tell them that, okay, and I tell my patients in my clinic, okay, this is almost the only difference between your previous colonoscopy and the current one is you will go through this procedure under general anesthesia so that the operating field is stable. And that's what I tell them that, and fortunately, my anesthesia group are very supportive, and they do put the patients under general anesthesia. And we have not had any problems with that in the last maybe 12 years. And the procedures go much more smoothly. And I also tell them that I want I want you to paralyze the patient, and I want you to maintain a low tidal volumes so that if the lesion is in the hepatic flexure or transverse colon, or sometimes cecum, they move with the respiratory movements. And that could be avoided by talking with the patient, with the anesthetist. So, all right. So what we will do is maybe next week, we will talk about loop ligation for pedunculated polyps. I think it's a good segue based on some of the input from Asmin and others. And we would like to hear your feedback about how things are going. And maybe in one of these sessions in the future, I would like to teach you all how to edit a movie so that you can learn the art and maybe bring cases so that we could discuss.
Thank you.
All right. Thank you so much.
Thank you, everyone.
Thanks, everyone.
Thank you.
Thanks,
Thank you,
everyone.
Selvi. Thank you. Thank you, Selvi. Thanks, Roy.
Thank you.
Thanks, Viram.
Thank you all.
Thanks, everybody.
Thanks, Raju.
Thank
Bye,
you.
everyone.
Thank you.
Have a good
Thoroughly
week.
enjoyed.
Thanks.
Bye bye. Have a good night.
Bye-bye.